Thank you very much, and I really appreciate being asked to come and talk here today. I know many of you aren't paediatricians, but I'm sure, and I really hope, that you will find some common themes in what I'm going to talk about. And I think that I don't really need to introduce anything, because everything that Melissa said, we will talk about. I'm guessing, because most of you aren't paediatricians. Are there any paediatricians in the audience? Paediatric nurse. Yay! 2. That I'm going to not expect you to do anything. I'm just going to go through a bit about what sepsis is, how we look at early recognition, how we manage it very briefly, and safety netting. And you can see the same themes coming through. So defining sepsis. In adult land, this is much more straightforward. But look at this graph. We know that 50 million people a year are affected by sepsis, and 25 million globally are children, but 20 million are under 5, so it's those young cohort. But what's really important is 75% of those deaths are in neonates, so they're in the first 4 weeks of life. And this is what you need to take away. Now, the problem with sepsis in children is, for a long time, from 2005, it was just expert opinion. We didn't have anything to really pin down what sepsis was. But last year, the phoenix rose from the ashes. So in 2024, we have new paediatric sepsis criteria from a 3-stage task force. But what is really important is that we have looked at higher income countries and lower middle income countries, because it's not the same for everybody. I'm going to take you back. I'm sure you know this. I'm sure you know this really well. But for me, I'm a simple person. I just need to start at the beginning. So to have sepsis, you must have an infection. And I would remind you that's not always a bacterial infection. So sepsis can be triggered by viruses, by flu, by fungal sepsis. Sepsis itself is defined as life-threatening organ dysfunction in the presence of this infection. And there are 2 types. So you could have a chest infection, like William did, and then die of respiratory failure. But you could have a chest infection with remote organ dysfunction. So you could have a chest infection with renal failure, which puts you in a more severe category. And then in the middle, you've got septic shock, which is sepsis in the presence of cardiovascular dysfunction. This is the actual criteria. You don't need to read this, but you need to know that there is a score. There is respiratory, cardiovascular scores, coagulopathy, and neurological dysfunction all score. You can't use this in clinical day-to-day practice. This is really, at the moment, a research tool, but that's important, because if you don't know what you're counting and what sepsis is, we're not going to come out with the same answers. So this is, at the moment, a research tool to make sure that we're all looking at the same thing. And there's a really nice flow diagram that says, here's an unwell child. Have you screened? And we're going to talk about that. Have you assessed them? Do they meet the criteria? And what you're going to do. So let's put some figures on it. And this is where it becomes interesting. I can see the paediatric nurse here smiling, because she knows what the problem is. We see a lot of children with temperatures. Any of you who've got children, your child at some point has had a fever. And when you come to the emergency department, 5 to 10% of all those febrile children have a serious bacterial infection. But only 1% have sepsis. So 99% are probably going to go home. But upstairs, in your paediatric intensive care unit, 10% of their admissions and 25% of their deaths are from sepsis. And what causes sepsis? So if you look at the red circles, that's neonates under 4 weeks old. You've got the things you would expect: E. coli, Klebsiella, Group B strep. And the blue circles at the bottom, when you look at children, the things that are killing children are strep, staph, and my favourite pathogen, other. And this is important because people forget about other, right? I am going to start by talking about low and middle income countries, because for too long we haven't thought this, they have the global burden of sepsis. So don't forget about malaria and dengue. If you look at the high-income countries, flu is top. UTIs, strep, staphs, but coagulase negative line infections, think about that. And think about things like meningococcal disease. I am old and I haven't seen a lot of meningococcal disease for a long time, and I've had 3 cases in the last 6 months. And this may be related to vaccination uptake, it may be something else. Now that cross there, that's my hospital in Newcastle. I forgot to tell you about Newcastle. Do come and visit us. It's a beautiful place. This is a map of deprivation. Dark red is deprived, right? So Newcastle is a town which is highly deprived. The grey area is our town moor, and that blue wedge, that's where all the doctors and nurses live. That's because that's their walk into the hospital. And I'm actually not joking you, that's Gosforth and Jesmond. So in the hospital I work in, it is a very deprived area. And it's really important to think, why is sepsis a disease of disadvantage? There are a lot of different reasons, okay? So why are children and adults vulnerable? First of all, if you look at the top corner, there are geographical barriers. So we have a huge county. If you're coming from rural Cumbria in your farm, it's a long way to Newcastle. We have very poor public transport, and we have less GPs per head population. So these are the kind of things that hamper getting care. And disadvantage also, I said to you vaccination, I'm going to say that again. Lower vaccination in COVID, people didn't get out, they missed their vaccinations. So children who are unvaccinated are at huge risk. And health literacy. Health literacy is really strongly related to health outcomes. And behaviour risks. So, oh yes, I forgot to tell you, in Newcastle, the average reading age is 8. That's what you're aiming at, right? And there's a high risk, there's a lot of behavioural risk taking, there's a lot of stress living in Newcastle, lots of smoking and obesity. We have long coastlines, so we have a very difficult geography, and there's lots of reasons. Oh, cultural aspects, there's another interesting thing. Housing is very cheap in Newcastle because people didn't know how nice it was, so they didn't come up here. But then the government realised it was really cheap, and so now all the migrant populations are being housed in block in Newcastle because it's cheaper than London. So I've talked to you a bit about sepsis. I've talked about what causes it, what puts you at risk, and disadvantage. And we're going to think about early recognition. And the good news for me is that lots of your next speakers are going to answer my questions. Now this, you would think this is a picture of Where's Wally, but it's not. This is a picture of your emergency department. I used to say on Friday night, but now I say every night of the week, right? These are all the hot cross children with their hot cross parents. And did you remember I said 1% have sepsis? So you are trying to spot Wally, but you have to send everybody else home safely. That is your job. By the way, if you haven't found him, I haven't got a pointer. It's sort of like 12 o'clock. So we all know about the Surviving Sepsis campaign with international guidelines, and the first recommendation of their 50 is that we should implement systematic screening, right? And that was great. The Sepsis Trust has done fantastic work. They've produced these screening tools, and I believe they work well in adults. But this is not the same in children. Now, who of you here have got children? Quite a lot. Let me ask you a question. Has your child had a fever? Does your child cry? When they cry and they've got a fever and they're cross, does their heart rate go up? Oh, how many red flags have you got? Has your child had sepsis? No, exactly. All right? So the problem is these red flags don't work in children. And my friend Ruud Nijman in London showed that. He showed that 41% of febrile children have red flags for sepsis. But they don't have sepsis because we know it's about 1%. So what are better screening tools? Now, in some ways, paediatrics lags behind adults. we haven't had a national early warning score, which is incredible, but it's true. But it's coming. So we've got this national PEWS that's rolling out. And this is some work done by the Alder Hey Liverpool group. They looked at 11,500 children. 10 died, 5 had sepsis. But the people who used their PEWS score, they've showed that all 7 PEWS scores recognized those sepsis-related deaths. And not just that, they picked up their critical care admissions. Because actually, although we're here for sepsis, we're actually interested in all sick children, right? So PEWS works, but it only works if you do it, right? Now, you're all laughing because you haven't tried taking blood pressures off toddlers, right? It's not an easy job. But if you miss out the blood pressure, you do not have a complete score. If you don't ask about family concern, you do not have a complete score. So compliance and observation compliance is vital. And my paediatric sepsis nurse, Fran, is sitting back there, and she's fantastic. And her nickname in the hospital is the OBS police. And that is so important, right? Because if you're not measuring it, you will miss it. And it's not just measuring it. Are you responding to those observations? Is somebody actually doing something about it? Or have you got, as the Ombudsman pointed out, 5 hours of red flag, high abnormal observations? The good news is AI is going to solve everything, isn't it? Now, this is from the States. This is a machine learning. So they looked at observations and they looked at data from medical records, so ethnicity, past medical history, that kind of thing. And they could predict sepsis better than SIRS and PLOD. So in the future, all this data should come together and should be able to label high-risk children. But it doesn't at the moment. AI isn't helping us at the moment, right? So we're not there yet. And this brings me to a really important thing, that part of your PEWS and part of what we hear about is family concern and talking and listening to families. And Melissa said this very clearly, and the Ombudsman said this very clearly, that actually this is vital. And there are children who are much more vulnerable to sepsis, where we need to do this even more. So children with complex medical needs, you don't know what they normally look like. Only the parent knows. Think about children with impaired immunity, unvaccinated, again. Children who've had surgery or got lines, those very young babies. Do you remember how long you walked up and down with that crying baby? You know exactly what normal looks like, right? So you need to communicate with these parents. And parents where English isn't their first language, because they're really disadvantaged. The NHS is not an easy system. You know it, you've grown up in it. But people who come into this country who can't speak English, they're like, what? Where do I go? Who do I speak to? It's really important. It's actually nice guidance that you talk to parents and you pay them attention. People have worried so much about Martha's Rule and how many calls they get, but this is a systematic review from Australia where they've been doing it for years. Over a 10-year period, they had 10 studies. Over 10 years, they only had 426 family-initiated calls. And in Australia, the parents were allowed to go and put a 222 crash call out, right? Yeah, think about that. And none of those calls were inappropriate. They were all deemed appropriate, and 3 led to immediate ICU admission. So parents don't overcall it. They don't worry unless they need to. I want you to go back and think and ask yourselves, Martha's Rule is about 3 things. It's about, are you asking parents if they're worried, or sorry, adults in your case, are they worried or concerned every day? Not just once or twice, every day. Are you asking the right question? It's not a yes-no question. It's like, we ask something like, how is your child compared to when I last saw them? Something like that. Is your parent empowered to reply? If I come up to you as the paediatric consultant and say, you look great today, you're like, yes, yeah, I look great. It's really hard to disagree. So are they empowered to reply? Is it documented? Does anybody ever write anything down? Is there an appropriate response and escalation? So it's quite a complicated task. The thing that I wanted to come back to, which I touched on really briefly at the beginning, is about health literacy. Health literacy is the most important, one of the strongest predictors of health outcome. So if you can't, and I told you that actually in Newcastle, the average reading age is 8. So it's all very well having lots and lots of lists to read. When you're sick, when you're worried, when you're panicking, you need really simple, clear instructions. This is what we use. So we say to parents, are you worried? We'll listen to you. We're empowering them. We're saying we want to listen to you. We actually are only worried about a few things if your child's in hospital. Have they got a new fever? Are they in pain? Things like that. So we tell them what to look out for and we tell them what to do. And there are simple pictures, so if you can't read, it's a bit obvious. So moving on from family concern, point of care tests. Luckily, we have hundreds of experts speaking after me, so I can whiz through this. For a long time, this entire conference upstairs has spent years looking for pathogens, haven't they? We've been hunting bugs. But that's a messy business, and it's a slow business, and it doesn't always work. And actually, we should have been thinking about our host immune response to those pathogens. So blood cultures, that technology hasn't changed since the 1950s, right? And we know that up in the PICU, 50% of our sepsis are culture negative. And I say to you, I know why, because there's no blood in the bottle. There's a little pink tinge, right? If there's no blood in the bottle, nothing will grow, right? So we know that blood cultures don't work that well. So what else have we got? We know that white cell count and neutrophil, look at those sensitivities and specificities. They're not great. CRP, better, but it's quite slow. The half time is 6 hours and your peak is 48 hours. So as William's mother said, you could easily be dead before your CRP has gone up. Procalcitonin is better, and today everybody else is going to tell you about what's coming next. I'm going to put a brief shout out to Perform. I've been working with the EU and their big Perform and Diamonds research team. And we have got new things like RNA signatures. And look at that, there's a clear water between the red and the blue, so you should be able to tell. This is the reason we want new tests, because we have little babies with fevers just like this. And actually, we do want to know whether this is a bacteria or a virus. But what we want to know is, even if this is a virus, is this the baby who's going to get sick and need critical care? So we want some sort of clinical predictor of severity, and we really don't have that. And we'd actually like a point of care test so that we could tell, is it bacterial versus viral, so we'd know whether to give antibiotics, and is this child going to need admission or intensive care, or can I send them home? Somebody else has got those answers for you, not me. I'm going to whiz through this because there's only one paediatrician here. In some ways, pediatrics was ahead of adults, so we already split our algorithm. So in suspected sepsis, if you've got a normal blood pressure, you've got 3 hours to do your 6 steps. But if your blood pressure is low, we've got good evidence that doing all of this within an hour is going to save lives. Oh yes, did I remind you that in children under 1, so between 2 to 3 kilos, you need 6 mils in that bottle. So if you're over 1, you should put 20 mils in that bottle. I mean, I don't think hardly anybody ever does that. This is the evidence that actually a bundle of doing blood cultures, giving antibiotics and fluids within an hour for those sick septic children makes a difference. So in New York, they did a huge quality improvement project right across the hospital. And they showed you there that if you look at 1 hour compared to 3 hours, the in-hospital mortality halved if you could do that within an hour. So it does work. Very briefly, antibiotics. People tend to have a real knee-jerk reaction to antibiotics. You come in, you've got a fever, and you get ceftriaxone if you're a child, and if you're an adult, you get tazobactam or something like that. But you do have to think before you just give that. So think about, what is the site of the infection? Is it a UTI? Do you need anaerobic cover? Where has your patient come from? So local resistance patterns. If they've been on holiday in Spain, there's a lot of resistant strep pneumoniae there. Do they have a line under that shirt that you haven't lifted up? Does that need to be covered from? Think about immunocompromised patients. Do they need broader cover? And particularly in neonates, think about HSV because it's devastating and you need to give acyclovir early on. And very topically, because of that drop in vaccination, we've seen a lot of pertussis. So very small babies under 1 month old die of pertussis. So coughing, febrile, ill, very small babies, do they need azithromycin? Fluids, we are moving, like the adults, to smaller boluses, 10 per kilo, and then reassess and decide if you want another one. And ideally, you'd have an echo to assess your cardiac function. But if you're not giving so much fluid, what does that mean? It means that you need to use your inotropes earlier. Okay, so after 40 mils per kilo, start thinking about using inotropes. And it's very easy. It doesn't matter. You've got adrenaline or noradrenaline, and it doesn't really matter too much which you pick first, because you're going to use one first and the other second. But the important thing is we have great evidence in children you can safely give this through peripheral cannulas. So don't faff around, just start it and run it through your peripheral cannula. In COVID, the London ambulance crew used NORAD in all their COVID patients in the ambulance, and none of them had huge problems. So I think that's a really big thing, and there's a really nice bit about monitoring there. So very briefly, safety netting, we're going to come on, and you can see all the themes are really similar. This is a medical legal standard of care. And you heard what Melissa had to say. And Sam is another thing. He was sent home and his mother wasn't told what to expect. And she also found him dead in bed. Ask yourself, when you're thinking about safety netting, what are you telling families? Are you telling them how to recognize deterioration? Are you telling them what's common and serious, what the flags are, and what you're not sure about? Because there's lots of things we're not sure about. Are you telling them when to come back for care? Are you going to get ill in the next 2 days or the next 2 weeks? When to seek medical attention? And more importantly, because I work in ED and we're overwhelmed, when to stay at home. And I'm not joking. This is the other side of the coin, that actually parents need to feel confident about when they can safely stay at home. And if something happens, where do they go? So we have people who are in very, very rural areas. Do they go to a walk-in centre? Do they drive all the way down to Newcastle? This goes back to what I was saying about health literacy is the most common reason for social disadvantage, right? So if you have poor health literacy, if you can't read, if you don't know much about medicine, maybe you left school early, you are hugely disadvantaged. You can't recognize if you have sepsis. You might not know where to go. You might be looking at social media and picking up false information like vaccinations are harmful, for example, okay? We tell people too much too fast, just like I have. But luckily for you, this is a website we have worked on, and it is going national. So this is Healthier Together. There are regional versions. So this is our Northeast Northumberland version. It is free. It is online. Half of it is written for parents and with parents and young people. The most important thing is that yellow box there. You just click it and you can text it straight to their phone. So as they're sitting in front of you, you can hear that ping as it lands on their phone. They can look at it all the time. They don't lose the leaflet. And it's got lots of information. And the Recite Me means that I can translate that immediately into 100 different languages, of which 60 are read aloud. So I would strongly advise, parents are telling us that they want digital information. So my messages are to you, screening is difficult in children. And ideally, we would have some digital solution, maybe AI in the future. We must engage in the national PEWS rollout. But talking to parents and communicating parents is what your core business is about. There's things that we don't do very often in pediatrics and probably in adults as well, which is like make-up inotropes. So our nurses sim that because it's something we don't do. And when somebody says, go and find the adrenaline, you're like, huh? I can only find Calpol. Invest in point-of-care trials because that's going to be your future, and safety netting. So I've put healthier together, the baby check. Also, we've done a new recognising illness in very young babies with the baby check group. Don't forget the Bubbles has incredible information. We have podcasts. And my last shout out is we have just written the first of our NHSE learning modules for sepsis. So we've written a community level one and we're just about to publish the hospital one. You'll be delighted to hear it takes 5 minutes and there are no ridiculous quizzes, okay? So please go and look at it and use it, otherwise I've been wasting all my time. This is our Fudge the Giraffe, and thank you very much.